We're going to go really fast through this stuff here, and it's a pleasure to be here, and I want to acknowledge my kind of partner in all things palliative at Baylor, Scott & White, Martha Filastri, who's helped me put some of this together. I'm going to be talking about not our experience with value-based care as a large not-for-profit healthcare system, but a large not-for-profit healthcare system moving from fee-for-service towards value-based care, and lessons that we've learned along the way. I think our experience in dealing with serious illness care actually begins before the concept of palliative care was there. I would date it back to the first hospices that came to Dallas in 1978. We all know the limitations of that. We tried to deal with that by then developing a very robust clinical ethics consultation process in all of our hospitals, and at one point we're providing in our academic hospital alone 150 consults a year. But that's 0.5% of non-obstetric admissions. So that serves a very small number of patients. With the advent of DRGs, we developed an in-hospital skilled nursing facility responding to those financial incentives to get this patient out of the hospital quicker into the DRG. We started to build a palliative care unit within the SNF, and then a perverse financial incentive came along that said, you know what, there's better uses for these hospital beds financially than the SNF. So our palliative care first effort was stillborn in the late 90s. Lesson I took from all that is financial incentives must align, and we're going to talk about that journey. We start with palliative care 1.0, as I call it, in 2002. We don't actually get our doors open to see patients until 2004. This is very much an acute death and dying services in 5 of 10 acute care hospitals in the healthcare system at that time. We had limited cost savings data to justify ourselves, and administrators were fairly loath to expand the service. They saw us as a cost drain. Bob, that's very nice, but that's expensive. Palliative Care 2.0 gets going in 2010, and it really starts when administrators, looking at the advent of what they believe to be value-based reimbursement coming down the pike, says, we know we have a lot of non-beneficial and unwanted treatment, therefore we have to reinvest in palliative medicine. We start moving away from part-time doctors to full-time palliative medicine physicians and APRNs. We open programs in 14 hospitals. We opened 3, it's actually now up to 5 outpatient clinics now that I think about it. And we start focusing not on the acutely dying patient in the hospital, but on the seriously ill patients in the hospital. And we start targeting 2 particular groups of patients, cancer and heart failure patients, and I'll talk about that some. And then 3.0 is kind of where we are now, much more robust specialty palliative care teams, and working on a primary palliative care initiative, simply trying to teach better communication skills using Atul Gawande, Ariadne's Labs, Serious Illness Conversation Project, having embedded that into our 2 major EMRs, and are taking a very systematic approach to training non-palliative care providers to utilize the conversational script and tool. The key thing in this journey along the way, and I don't know that I have a pointer, is this right here. At Palliative Care 2.0, leadership said, well, we think at least 5% of our patients in our hospitals ought to be seen by palliative care teams, and we're going to mandate that. And I said, well, you can't do that because you don't have palliative care teams everywhere, and they're not equally robust. And so he said, well, I'm going to mandate the creation of the teams, and the way I'm going to do it is tie part of the executive incentive plan to developing palliative care. And that was a huge change. And with 3.0, they've gone from not just incentivizing building the teams, but incentivizing supporting the teams in such a way that certain outcome measures can be met. So this second effort to begin palliative care in 2002, as I said, it maxed out at about 1% of hospital admissions. The financial incentives weren't aligned, and one reason was we didn't have good enough data. We would quote Sean Morrison's study to them. There's Sean, and they'd say, well, that's in New York and other places. That's not Texas. Show us what we can do. And by the way, Bob, you have really high hospice enrollment across our healthcare system. How do we know it's going to benefit? So we had an economist working with us at a time. We basically duplicated Sean's study system and wanted to know, would we get the same results in our system? Would palliative care lower direct costs? Because that's the only way we were going to get this thing funded. in a system that already had high hospice utilization and had some other questions. And we did have this very high hospice enrollment already. In bold, you'll see the Baylor Healthcare System Academic Hospital and the community hospitals compared to the hospitals in Sean's study. And people were saying, we don't think palliative care is going to save money. But it turns out it did, but there were caveats. And you see some of those on this slide here. Anybody discharged deceased, there was money saved to palliative care, cost savings, direct cost savings, not charge avoidance, direct cost savings. But for those discharged alive, if we didn't see them early, we couldn't show the direct cost savings that administrators wanted to see. It was just a reality. So lesson learned was late consults were not only bad for patients and families because they weren't getting the service they needed, but they were bad for the financial model we were trying to build this under. We found out that for us, at least, primary diagnosis mattered. At any point in time, if we saw a cancer or cardiovascular patient discharged alive or discharged deceased, we could show direct cost savings. Certain other disease categories, that was harder. We're not going to turn down patients because they don't have cancer or cardiovascular disease. But we started marketing more to those groups to increase our involvement with them. It's to the point where everybody coming to Baylor University Medical Center for an LVAD or a heart transplant actually meets the palliative care team for what we call preparedness planning. And hopefully most of those patients will get their LVAD, and as many as possible will get their heart transplant. We really have to stay on top of finances. And so we use the CAPC calculator, and we remind our hospital administrators of this. We are funded, or we are subsidized. Each team is subsidized by the hospital president of that hospital among the 14 where we have teams. So we're constantly, we plug their individual data into this, and we say, this is your direct cost savings that you can expect. They still kind of go, well, doesn't quite feel the same as the money that I get when we do a cardiac cath, right? So it's still a challenge. Some lessons learned over this journey then. Hospice is essential. For me, it's the gold standard of care for the very last part, the very, very end of life. But it is not sufficient by itself to achieve all the improvements we need in serious illness care. And that's become apparent listening to everyone speaking here today. Clinical ethics, we happen to think, is essential. Having a robust program that sets the moral plane that we expect people to operate on in the end of life is essential, but again, not sufficient. And palliative care is obviously the solution, and everybody here is very familiar with all the benefits. There are some commitments that I think need to be made to make this work. And by the way, I'm talking from a state where less than half of hospitals have palliative care programs. That's the reality in Texas. And so some of what I'm telling you is stuff that I tell state leaders and other hospital systems in Texas. I think there needs to be external validation of quality, and we rely on Joint Commission to do that. And as our teams develop their metrics and get strong enough, we apply and we work to achieve that. Lots of robust data collection is needed, and we collect about 40 different items. I think it's 48. But some of the ones that we focus on, as you can imagine from what I told you, timeliness of service. Because if we see the patient late, there's no direct cost savings. Care planning. Are we achieving new advanced directives? Are we achieving appropriate code status changes when it's appropriate? Are we improving pain or other symptoms? We also think it's really important in adult medicine to support the children of seriously ill adults. Most programs aren't doing that, and I don't see how you fully support the family of a young man or a young woman or a grandma or grandpa of a 4-year-old or a 14-year-old. They're dying, and as an adult doctor, as a geriatrician by background, I don't know how to talk to a 4-year-old or a 14-year-old about their loved one dying. So bringing child life into the mix, I think, is absolutely important. There are some truths that I'll close up with, kind of regardless. We're at a point where our administrators are saying, gosh, we want more value-based payments, but there are only about 548,000 covered lives in our ACO right now. For a big statewide organization, that's not much. About 110,000 Medicare shared savings plan lives covered. And so a lot of our programs are still operating in a fee-for-service world. It's just the reality. We can't fund comprehensive primary and specialty level palliative care from professional revenue alone, so we have to keep focusing on the cost savings. We do think value-based payment would be better for us, but it's not fully there yet, and that's complicated. One of the challenges in either system, as this audience knows very well, this is a team-based service. But in traditional fee-for-service models, you can only charge for the physician to the APRN. We have about a 1-to-1 ratio in our programs of physician to APRNs. And we are, as everybody here knows, seeing the sickest of the sick. The sicker you are, the more complex the case, the greater the time commitment. And despite the wonderful payment for advanced care planning codes that Medicare has now approved, it still doesn't cover the full time involved. Another lesson for us learned, all healthcare is local. It's a long way from a 30-bed hospital in rural central Texas to the Dallas-Fort Worth Metroplex hospitals. Lots of challenges. We haven't figured out how to do that in the smaller hospitals yet. We do think data is critical, and we divide our data into two pieces, the data that touches the heart and the data that touches the head. And we think that's important in bringing this along. And the last comment would be that I think one thing that helped palliative medicine grow in our healthcare system was a senior leader who said, we're going to put incentives in for every senior leader in the organization to build this program. And he said that for two reasons. It was the right thing to do. He believed, as I believe, and I think everybody in this room believes, it's absolutely essential to being prepared for the coming of value-based reimbursement. And so that's that. We'll skip.